Hi, my name's Rachael and I'm an advanced care paramedic with Queensland Ambulance Service. Today I'm doing this video to show you cold intubation. Cold intubation is a skill that most intensive care or critical care paramedics have, and the most common setting is for the use in the out-of-hospital cardiac arrest patient. Cold intubation is an intubation that does not require pharmacological intervention such as anaesthetics, paralytics or analgesia. Cold intubation is contraindicated in any patient that is spontaneously breathing and maintaining their own airway and are conscious. To start off with, I just want to put a large emphasis on the most important part of our technique of cold intubation, which is working as a team and communicating well. We're going to start by looking at our equipment setup. And most commonly, the gold standard for this is to have your equipment on the right-hand side of you and your patient. With all your equipment laid out, including some failure equipment for an unsuccessful intubation to allow you to follow the failure algorithm. To start off with, we're going to talk about the setup of our intubation. I've got a full oxygen bottle over here, and I've got my suction, my Yankasaka, underneath the right shoulder, which is a gold standard placement for these techniques. Next to me, I've got my BVM, which under the assumption of an out-of-hospital cardiac arrest that we've had adequate pre-oxygenation, with capnography attached, as that is the gold standard for recognising correct placement of an ET tube. I've got a stethoscope ready to do my checks once I've got the tube in. I've got multiple ETs here. For the sake of this video, I'm using a size 7 ET in the flexi-tip tube. In QAS, we use size 8 and 9 for adult males, 7 and 8 for adult females, and then our paediatrics go down to a 3.5, which we assess our ETT size for paediatrics based on the formula age divided by 4 plus 4. For the gold standards for the placement at the lips, for an adult male is 22 to 24 centimetres, for an adult female is 20 to 22 centimetres, and for children is age divided by 2 plus 12. It is important to have a couple of different sizes, at least one above and below the size you're intending to use, in the case of an anatomical anomaly, particularly in the patients where you're concerned of airway edema such as smoke inhalation, carbon monoxide poisoning or anaphylaxis. We then have our failure airways, including all our sizes of OPs, nasos and LMAs as well, in case they're required. We've got a bougie, which in QAS is required to be used with every intubation, which is quite conservative in comparison to other services. We have our laryngoscope. We use the Macintosh curved blade in size 2, 3 and 4 for adults and large children, and we have the straight blade, which is the Miller blade, in size 0 and 1 for paediatrics. It's important to ensure your LED light is working and that you're happy with the equipment. We then have a 10ml Luolox syringe to inflate the cuff. We have a manometer in QAS to assess cuff pressure, which is a very valuable piece of equipment. We've got lubricant. We've got a stylet, which it is up to your discretion whether or not it is used. It helps to maintain the shape of the ET tube. And then we've got the Thomas tube holder in QAS, or we also have cloth tape, and it is up to the paramedic discretion which one is to be used. Also ensuring we've got safety goggles and gloves, which I'll get before we do our intubation. It is very important to discuss with your team their roles in airway management. As a CCP, coming into these cases is important to demonstrate good leadership and ensure that your airway assistant is aware of the equipment and what is to be done. When you take over the airway, it's important to choose your airway assistant and ask if they have assisted in intubation before, and if not, familiarise them with the equipment and how you want things done, as you do not want to have a bougie in place and having a tube handed to you that is the wrong way being threaded as a result of someone that's never seen one before. We'll quickly mention as well to inform your airway assistant about burp, which can be used if required, which I'll demonstrate in a moment. I will now get my airway assistant Ben to please join me. So initially before intubation, the technique itself, first of all, is a visual assessment. So I'll just get Ben to, if you wouldn't mind, just assessing the cuff, making sure there isn't a cuff leak, inflate, deflate, and pop some lube on, and familiarise yourself with the equipment while I quickly assess the patient. So we're starting with a visual assessment of the airway, looking for any obesity, fat neck, beard, anything that's going to show us that we could have a potentially difficult airway, at which point we would have surgical airway equipment and things like that ready as well. Then looking at the position of my patient. Now obviously in a cardiac arrest situation we would be on the floor, but for the purpose of this video we are elevated on a stretcher. And I would make sure that I've got a cushion, whether it be a pillow or a towel, under the patient's shoulders to give a good sniffing position and align all our oral, pharyngeal and laryngeal axis. Obviously in a C-spine patient we wouldn't require that. So to start off with, Ben, like my laryngoscope please. So we're going to start off with our procedure for intubation. First of all, Ben, have you assisted with an intubation before?
No.
Okay, great. Have you heard of burp before?
No.
Okay, if I ask you to perform burp, I would mark the thyroid cartilage. It involves putting backwards, so back, upward and rightward pressure onto the thyroid cartilage, which I've pre-marked for you.
Oh.
I only do that if I ask for it, if I require it. For the bougie, I'd like you to place it to me when I ask for it that way down, like this, with that little eyelet there. And then when you thread the tube, it is going to be thread in that direction.
Yep.
And I will inform you when I'll take over that.
Lovely.
So to start with our laryngoscopy, positioning the patient in a sniffing position, holding my thumb on his forehead, and inserting the blade into the right hand side of the mouth and sweeping towards the left and lifting up to visualise the chords. So can I have my bougie please, Ben? So I'm visualising the bougie going through the chords. And now I'm going to get you to thread that ET tube through there for me. And once that meets my finger, if you could hold on to the bougie and make sure that stays still. Now I'm keeping an eye on my black ring markers there to ensure that they go through and are sitting in the middle of the vocal cords. Keeping my visualisation. I'm now 22 centimetres at the lips. I'm going to remove my laryngoscope and I'm going to get you to pull out the bougie please, Ben. Now I'm going to get you to connect my BVM for me. Thank you. And that is hooked up to CO2 monitoring. And we're going to inflate the cuff. And using the gold standard QAS, we're going to use the manometer once inflated to ensure we've got adequate cuff pressure. So I'm going to start ventilating, looking for adequate rise and fall, which as you can see I am getting. And using our gold standard capnography to ensure ETT placement, we want to have 6.
In the green.
Thank you, Ben. We want to have 6 continuous moderate waveforms to ensure placement. So Ben, if you wouldn't mind holding that BVM for me. I'm now going to secure that using the cloth tape and the method QAS specifically like used. We're going to tie a surgical knot, which involves a normal knot with an extra loop through, above the ET tube, over the top teeth. And we're then going to do a reef knot, which involves threading those around and then doing a normal knot. Making sure we're still 22 at the lips and inserting a bite block as well. And now I'm just going to quickly have an auscultate and ask Ben to ventilate for me. Perfect. That is, thank you Ben, thank you for your assistance.
Thank you.
That is our that is our entire ETT technique. For the purpose of the video, I'm not going to continue ventilating, that is the technique complete. What I want to discuss quickly is just a couple of complications, including a cuff leak. This is very common, whether it be that it is a fault with the ET tube itself, but does need to be rectified as it can result in aspiration or failure to ventilate and oxygenate, which obviously you'll start to see decreased tidal volumes, decreased perfusion, decreased SpO2 and a difficulty ventilating the patient. Obviously in QAs having the manometer allows as a fail-safe to ensure that we're not having a cuff that's leaking, but the gold standard management to fix that is to remove the tube and attempt a second intubation. Another common complication, particularly in the out-of-hospital cardiac arrest, as this setting is passive regurgitation despite intubation. Suction sometimes is not enough to alleviate this problem, and in QS we're indicated to insert an orogastric tube, which is a tube inserted to the stomach via the oropharynx to facilitate gastric suctioning and gastric decompression to prevent further regurgitation. Overall, intubation is a very simple skill in itself. However, if you are not familiar with your equipment and the optimum positioning and good with your leadership in your team, it is a technique that could result in an array of complications. Hope you've learned something from this video.